Welcome to the Listen Up podcast, where we explore hearing loss, communication, connections, and health.
Hey everybody, Dr. Mark Sims here. I'm the host of the Listen Up podcast, where I feature top leaders in healthcare. This episode is brought to you by Listen Up Hearing Centers. I help patients to effectively treat their hearing loss so they can remain connected with friends and family and remain independent. The reason I am so passionate about hearing loss is because I lost my brother Robbie twice. First to his hearing loss from his brain tumor, and then again when he passed away. I only care for ears. I'm the E of ENT. I've taken care of tens of thousands of patients with hearing loss and performed over 10,000 surgeries over the past 20 years. I've also written a book called Listen Up, A Physician's Guide to Effectively Treating Your Hearing Loss. If you want to learn more about the practice or about the book, go to listenuphearing.com. Today, we have a great guest. We have Dr. Jed Grisel. He is a fellow otolaryngologist who completed his undergraduate training in Biomedical Engineering at Texas A&M University and finished medical school at the same place at the University College of Medicine at Texas A&M. He did his residency at a great program at University of Cincinnati, and now he's practicing head and neck surgery at the Head and Neck Surgery Surgical Associates since July 2011. I noticed that he's speaking in a coming up cognition and audition summit, and that's kind of what spurred me to have him on as a guest, and it's an exciting topic to explore, and I'm really excited to have him on today. Hey, thanks for coming on. Welcome to the show.
Thank you, Mark. I appreciate you inviting me. Any opportunity that I can get to talk about hearing loss and how it affects our lives is exciting for me. So thank you for the invite.
Great. Well, so at one point you were a baby little aspiring ENT, and now you're a practicing ENT who just said, anytime I get to talk about hearing loss is a great time. Tell me a little bit about that journey, how you went from being, somebody, I mean, we all come in with an interest in the field, but what spurred you on to kind of leak that statement you just said?
Yeah. So as you mentioned, I studied biomedical engineering and undergraduate training at Texas A&M, and I really enjoyed, when I was in undergraduate training, I enjoyed the signal processing stuff that we did, processing signals from the body. And so,
right.
And I love gadgets, right? Like technology and things like that. And so when I got into training in Cincinnati, I also loved ear surgery. And so I think that all those things, like I love the intricacy of the anatomy of the ear. I enjoy the signal processing part of the audiology. And then that all sort of combines on a very important and under-recognized problem that the world is facing. And so I think those things all sort of combine, and that's where my love is.
Yeah, that's great. So tell me a little bit about like what type of things you're working on in that space. And so, I mean, you were telling me in the warm-up that, you do ENT by day and hearing loss by night. And I think you do some of the hearing loss by day, but tell me a little bit about that when you kind of make those statements.
Yeah. So in my day job, I have although I do ENT, I do other parts of ENT as well, but I do, manage patients with hearing loss and medical and surgical aspects. But the other part of my job is I work with a group called Amptify. And so what we do at Amptify is we install audiology as a service line into optometry practices. That's sort of the other half of my life.
Sure.
And we partnered with a group out of the United Kingdom that does this, and they have audiology in something like 250 optometry locations, and they're the fastest growing hearing clinic in the United Kingdom, and now we're expanding to the U.S. And so we have locations in Dallas, Austin, and now we're launching several on the East Coast. And we just started less than a year ago, and it's very interesting when you think about the synergies of that and how we can access more patients and improve care for hearing care in the United States. So that's kind of my second job.
So there's some interesting challenges I'm sure you've come across already in the first year. Like, so what are those things in terms of the delivery of the health? I'm not talking about cash flow and things like that. We'll leave that out. I'm talking about more practical clinical issues. Like, so what are some of the challenges you face?
Well, so people who, it's funny because people have tried this before in the United States. And I think there's other folks who have tried that are doing this now, and it's had some spotty success. And then in the UK, pre-2008 or so, it was also like the US, pretty spotty success. And then there's a company in the UK called Specsavers who successfully implemented that. And now about 70% of the optometry clinics in the UK have audiology as a service. If you're an optometrist and you don't offer this, you are lacking in your service offerings to your community. So in the US, I think the reasons that have failed is I think the business model has been lacking, in which you have an ophthalmologist or an optometrist who says, I want to start selling hearing aids. And they don't really think of it as, audiology is a profession, right? And this is a service line that needs to be thought of carefully. And then also, most optometry clinics don't have the volume in one single location to be able to just hire an audiologist, have them on staff, and be busy, right? And so our model is a little bit different. Instead of employing audiologists, what we actually do is we create business partnerships with them. Our company provides the back-end business support, and we have a partial ownership. The optometrist has a partial ownership, and then the audiologist gets to own their own business, right? Which is good in many ways, right? Like when you are the owner of your own business, you think about it a little bit differently. And so, so what we're finding is audiologists that come and they're 3-4 years out of school, they've got their clinical chops under, they know how to take care of patients.
They've got their practice part kind of mostly mastered.
Yeah, but they want to do more, but they don't want to work for a manufacturer. They don't want to take out a $500,000 loan, and they don't know all the business side of things, right? So that's what this offers them, is they get to have ownership in their business, and then we bring all of that expertise to the table. And then we also keep them busy, right? So we find the optometry partners that we work with, and we decide, are you going to service 2? Are you going to service 4? How many is it going to take to keep you busy? And we have some ways of thinking about that. And it really is very unique. It's respectful to the profession of audiology. It brings them to the table.
Sure.
And we just have great relationships with these folks. And so it's an exciting thing that we're working on.
Yeah, I think it'll be great. I'd love to, visit with you a couple of years down the line to kind of see where it's all grown to and everything.
Sure.
Obviously these things don't happen overnight. So I'm sure the lessons that you'll learn the next 2 to 3 years will be interesting and substantive, just because as you scale, it just has its challenges.
Absolutely.
So, well, that's great. And there's other areas where, I came across, I think you're going to a meeting where you're talking about cognition and things like that. And I think that that's a really interesting thing because, I know we know about it, but I think, the ENT's perspective about that is an interesting one that's worth exploring. So tell me a little bit about that.
Well, I think the first thing to put out there, Mark, is that, we're early in this audition cognition journey. We've known for decades that there's this relationship between hearing and brain health, but there's a lot of interest in this right now, and there's data that's being published. And I think the way that the relationship that we have to cognition 5 years from now will be different than it looks today, and the way that we think about screening. And there's a lot of questions that still need to be answered, but here's my take on this: is that, dementia is a multi-trillion-dollar disease,
Okay.
as it devastates families. It's a gigantic health problem, and it's growing, it's blossoming, right? We all know that this is a huge problem, causes families to lose their independence, or loved ones to lose their independence.
Right.
And it's just a devastating disease. And the progression of cognition of neurocognitive diseases there's this window, this mild cognitive impairment window, which we can measure, and we can actually identify if a patient is in that phase. And that phase is defined where you have measurable decreases in cognition, but they have not yet developed decreases in their activities of daily living, right? So there's this window, and and we know that it is we don't have really good treatments for that late phase, right? We have some medications, that we can use, and there's some things that we can do, but we don't have like a slam dunk treatments for late stage dementia. So really the strategy right now is like, let's see if we can identify people during this phase, and then deploy interventions that can lengthen the time of MCI. But then you ask yourself, who in healthcare, like like, let's take a 10,000 foot view. Who in the healthcare system is prepared and poised to identify these patients, right? So if you ask a psychiatrist or a neurologist, or if they are interested in MCI patients, they're going to laugh at you, right? That's not what they're trained to do. They're trained to manage these patients once the disease is at a more advanced stage. You go to the primary care docs, and there's no way that they have the time or bandwidth to be identifying or screening these patients. And in fact, the U.S. Health Preventative Task Force has said that in a primary care setting, it's probably not a good use of their time, right? And so then you're like, well, who can identify these people? And one of the things that we do know, and we just have a recent publication on this, that there is this huge overlap in people with sensory deprivation and people with mild cognitive impairment.
Right. Yeah.
Right. And so the folks who are in the health system who are engaging on a regular day-to-day basis with people with sensory deprivation are the ones who are probably the most suited to identify these people. And by the way, then once we identify them, we have interventions that can make a difference, right? So managing the hearing loss. And so vision clinics, hearing clinics, ENT, these are people that are probably more suited. Like you and I have patients coming through every day in our office who complain that they can't hear, that they can't remember what people said. These are people that you would want to identify in that scenario. So that's my interest as an otolaryngologist. I think we can just make a difference, and we're not doing it right now.
Yeah, I mean, as you know, I mean, we're both outside of training. That really wasn't in our training, right? So
Sure.
It's something that is being created. I mean, I think one of the struggles is kind of the referral pathway from screening identification to mitigation and management is very challenging. And so despite the fact that there's a large disease burden, meaning there's a lot of people that are going to have it, I'm not sure the infrastructure is built out to actually deal with all of these. So, if you're, let's say, for instance, on a mild side, I'm identifying, 2 or 3 a week, which I think is probably an understatement of what I would identify. I'm not sure I have a place to send them.
Right. Like, what do you do? And so those are some of the things that we need to figure out. And, so there's about 18% of the people with MCI will convert to dementia every year. If we could extend the MCI phase for an additional year, that would by 2030 we'd have 10% less dementia. So I mean, these are, even though these are numbers that would be meaningful to our system. And you're exactly right. Like, we need to figure out, like, okay, so you're a hearing care professional, whether it's an audiologist or an ENT, and you identify a person with this. So what do you do then, right? Like, how do you do that? Right. And so we need to figure out, who do you send them to? Do you treat their hearing? Do you treat their sensory deprivation first and then see what's happening? And by the way, what does the screening mean? We know that, like, we do cognitive screening in our practice on all of our patients who are considering a hearing intervention, but we're very careful at this phase to not translate that into prognostic. We don't tell patients, okay, you scored X on your screen, that means you have such risk of dementia, because those questions are data. We don't know yet, right? Yeah, so we don't have those answers, and so we're very clear because if you don't, it can scare patients. But what we do tell people is, say, look, we know that for you, being able to hear, so audibility, and be able to make sense out of speech, which it would be listening or top-down processing, or whatever you want to call it, that requires your ear and your brain, and we want to be your hearing health provider. And if you're going to embark on this healthcare journey with us, treating your hearing loss, we want to know as much about what tools you have in the tool bag before we go and embark on this journey together. And so for us, it's really helping us to add one more sort of parameter to what skills that patient started with. And frankly, I think in 2022, if we're not thinking about it that way, we're doing a disservice to our patients.
Sure, I agree. Just to add, I think the other thing obviously is, and this is kind of that harder lift, is getting people to talk about, be willing to manage the comorbidities that they have, and getting them to understand that those are contributive factors. Unfortunately, I think we're all seduced by one thing, right? Like if I could just take a pill or get hearing aids and that would take care of it. But the real answer is going to have to be multifactorial, right? And so can't have, elevated cholesterol and atherosclerosis and maybe notice a marked mitigation of your cognitive decline by treating your hearing loss. Now, on the flip side, the argument is, well, if you've got atherosclerosis and hearing loss, you've got a double whammy. So at least we're helping mitigate one. So I agree 100%. It's just kind of that global health, overall health of a patient and how that affects their cognitive status.
Yeah. Well, and I agree, Mark. And so like, if you look at what are some of the top reasons why somebody might have MCI, like why somebody who performs poorly on a cognitive screener.
Right.
Okay. And I think it's important too for listeners to know that, we're not diagnosing people. We are not the ones making these to make a diagnosis of a neurocognitive disorder requires someone who's trained in that area, who does a proper history, physical exam, looks at testing, and then kind of puts it all together. So we're not really doing that. But let's just say for a second, what are some of the reasons why someone might perform poorly on a screener, right? Polypharmacy is a huge one.
Right.
And in the population who has hearing loss, there's a high percentage of polypharmacy.
Well, they thyroid, don't understand the directions of the prescription.
Right. I mean, it's a huge issue. Depression can present as MCI, thyroid disease, sleep apnea. So that's why the neurologists get nervous about this, because if someone performs poorly on a screener and we sent them to the neurologist, they're going to say, what am I supposed to do with this? Right. Like, they're not having, reductions in their activities of daily life. They need to see their primary care doctor. Right. But then you send them to the primary care doctor, and the primary care doctor is like doing meaningful use stuff and like cramming 500 things into a 12-minute visit. And so and they're not really aware of this whole issue. And so that's the challenge I think we have, is to get to the awareness to the point of like, yes, we can make a difference and we can identify these patients, but how do we as a ecosystem manage these folks?
Well, I think the answer, personally, is empowerment, right? In other words, similarly, when you do a procedure, you oftentimes give them the risks and complications of the procedure, right? And then ultimately they decide based on that litany and trying to contextualize it, whether or not they proceed and they think that benefits outweigh the risk. Well, to some extent, I think it's the same on us too. Like, here are the other comorbidities that can afflict people and worsen it. They're going to have to become self-advocates, because I think it's only, we can talk to our colleagues and they'll say yes, but it's only when that patient is right in front of you saying, Dr. Sims, I think I have a sleep problem and I know that can worsen my cognitive ability. Can you please work it up? And I think actually you're also speaking to, if there are any neurologists out there listening to this, it sounds like to me, you could have a booming neurology practice just taking care of people with mild cognitive impairment.
Yeah. Yeah. And I think, one of the things that I hear from folks a lot is both ENT colleagues as well as audiology colleagues is, they get nervous because they say, is this outside of my scope of practice, and if you think about the history of ENT as a specialty, like we work with oncologists all the time on patients. We work with endocrinologists, I don't think there's any reason why we shouldn't, just because a health problem afflicts our patients that we can make a difference on, doesn't mean that, we shouldn't feel like we have to shun that, wall ourselves off from that just because we might have to collaborate with some of our other colleagues. I think
I think people will make it in their scope of practice if the framework for them to integrate it with all of the associated knowledge or things are there, right? Like, so,
right.
So if it's not just, one of the problems is you can't just, we do the Montreal exam, right? And so, you can't just go get trained and start doing it, right? Like, you actually have to have like, okay, now we have a positive result. How are we going to discuss this with our patients? How do we present it to our patients? How do we help them? Yeah, I'll tell you, I've had patients who have had pretty significant cognitive impairment. You send them back to their primary care and you suggest, well, maybe you should have them see a neurologist who specializes in this, and it goes nowhere. They go and they come back and say, well, they said it wasn't anything. And so I understand what you're saying. We just have to feel more comfortable to make that strong recommendation of what you need to do. And so that's stuff that will evolve through our profession, through the residency programs, maybe through the academy, different ways to be able to talk about it. Like you can't just say, well, hey, you have a cognitive screening and it's positive. I mean, you have to be able to say, this is what
it means.
This is what it means. This is what you have to do with it. And that's, kind of, I mean, if you think about it, I mean, I'm not, but balloons, right? So for instance, I do eustachian tube balloon dilatations, right? And so that's a new procedure that there's kind of have to be some protocols, like what medical treatments you need to do before you do it, right? What's the pre and post? I mean, it's all a new thing. So I think it's when people say scope, they might be actually telling you they don't want it in the scope of their practice. I think it very much is in the scope of otolaryngic practice, how hearing loss impacts cognition. Audiology, I think it's a little bit different. I'm not saying they should or shouldn't. It's just whether or not they have the comfort on the medical side to have the ability to discuss this. I mean, I will tell you, I had an audiologist here who started doing the cognitive screening and then started talking to a patient, and the patient just stopped and said, and I'm not saying it's right or wrong, said, you're an audiologist. What do you know about this? Right.
Yeah.
And so I don't think that patient's necessarily right, but that audiologist has to be ready to not just say, well, you're right. I'm sorry. I shouldn't have done it. They need to actually be in a position to say, the reason is X, Y, and Z. And what I can tell you is you need to do A, B, C, D, and E. And so that's just evolution.
No, it's a good point. And that's a lot what this cognition and audition summit is about. Like I said, this is early in the process, but it's starting to get this help us, as a profession within ENT and within audiology, wrap our minds around where do we fit into this space? How can we make a difference? How can we practice within our scope and yet still help patients? But I'll tell you, this is not a new concept for audiologists to understand the ear-brain relationship.
No, yeah. I mean, even us too, right? I mean, just because you hear Mandarin Chinese doesn't mean your brain understands it, right? And that's a pretty gross example, but we all know that the brain is intricately involved. And then more sophisticated things, hearing and noise, filtering, also. I mean, it is not just the detection of the cochlea by any stretch. And that's actually why cochlear implants work, because the brain can help.
Well, and Mark, I'll tell you, in our practice, what we're seeing, and we don't have the size yet, I think, to make this really, to publish this yet. And we're growing in this sort of situation. But what we're noticing on our cochlear implant patients is that we measure cognition on every patient pre-op and then at 6 months post-op. And one of the things that we're noticing is that if a patient starts their journey, like if before their cochlear implant, if they have really good cognitive skills,
they're going to do really well with the cochlear implant
in quiet and noise.
Correct.
If they start and they're down in the dumps in terms of their cognitive ability, and we measure executive function, working memory, and visual spatial processing, those are the domains that we measure. If they're down, if they're really poor, scoring poorly, we'll be able to help them with speech and quiet. But the speech and noise we struggle with. And you know what? Being able to have that conversation with the patient beforehand,
agreed,
it makes a huge difference.
And that's actually, so I'll tell you the back end. I mean, we started doing, frankly, we've been doing the cognitive screening for about 6 or 7 years. And so it wasn't because, the studies came out or anything. It was off of clinical experience. And so we had multiple patients who would come and bitterly complain about not performing to the level they wanted. And there's one guy, I'll tell you, he's a very nice man, married, very nice wife, but there were some signs in his body that had indicated he had done a little bit of hard living earlier in his life.
Gotcha.
And so he complained, and we would say, well, you need to, and I think he had some depression as well. And so anytime we tried to pull it back post-implant to, it might not be the implant. I mean, he would want to get reprogrammed, he wanted integrity tests, he wanted all of this stuff. And the issue was, we were trying to demonstrate, unfortunately, post-implantation initially, that there was a cognitive issue, and it was that he couldn't screen it. And so when that happened, then we realized we're going to do this. So we don't do it on everyone, because what we're doing is pretty time intensive. But if there's any suspicion or any complaint specifically about hearing and noise, those types of things, we screen them, because agree, we use it as a pre-counseling tool. Because as you know, they can get a cochlear implant. The biggest problem with cochlear implants is not that they don't work. The biggest problem is patients are dissatisfied with the outcome after implantation. Right. And that's actually the biggest consumption of resources of the postoperative period is dissatisfaction with outcome. And so I agree with you 100% that it's a great way to try to figure out if people aren't going to do well in noise. So.
All right.
I
think that might be you.
All right. I usually turn it off.
No worries.
Anyway, so where do you see this going? So 5 years from now, where do you see this going, Jed?
Well, the device that we use is this an automated cognitive screener. And I think that it's called CogniView, but I think that the value of that is that, one, you don't have to have we got to make it easier, right? So you don't have to have a trained administrator.
And it's reproducible.
It's not dependent on a person's vision or dexterity to be able to perform the test,
right? Which
is a lot of our patients struggle with this. So I think we need to that's one thing, is I think we need to get the testing more standardized and doable in the real clinical setting. I mean, you are a leader in this space, and somebody outside of academia who's doing a MOCA is admirable, and that's that you're really taking the lead there. But to get the rest of us,
it's not scalable.
It's not scalable, right?
So I actually think you're going to need people are going to have to try multiple different things, and you're going to find that there's not going to be one tool. There's going to be 3 different tools, and you're going to have to kind of apply them differently depending on the circumstance. So I'm just making up the number.
Yeah. So I think we need to make the testing better and easier. I think we need more data of like, what do the scores mean? Right. What does a score of X mean? And that would be helpful. And then also, like, some of this data that's coming, that we'll be seeing soon with the Achieve trial and some of those things of like, how do hearing interventions influence? Yeah. So I think as some of that stuff comes in, we'll really wrap our minds around this better.
Yeah. I will say though, I mean, maybe, the role that we play is truly as a screener, right? Positive, negative, and maybe getting deeper into that might be beyond our bandwidth.
Yeah.
And so I'm not saying that you're not right, but then the question is can we create either within our own practices a system to like, okay, you have tested positive for mild cognitive delay, then we put you in a different pathway where the counseling is different, or a second tier test, right? So I think that might be it, because you want something fast and easy. Even the CogniView might be more extensive. If there were 3 things you can, there are things in neurology, right? Mini mental status exam, all of these things, but but you're right. Something also automated, right? So I agree. And so but you got to start the dialogue. So I admire the company for taking a big swing at it and seeing where it is and where it ends up. So.
Yeah. So I think it'll be exciting to see the next, few years as this really comes out and people start becoming more aware of it, and, onward and upward.
I agree. I think one of the things I will say is if we are trying to mitigate any risk of cognitive decline, then we need to make sure that we're actually mitigating people's hearing loss with verification. And so it's amazing how the two will tie together, right? Because there's a lot of unverified treated hearing loss. And so, it'd be kind of like saying, I'm treating your blood pressure, but your high blood pressure, but it's still 150 over 90. Well, that actually is less high blood pressure, but not treated high blood pressure.
Not treated high blood pressure. Right. So what are the numbers that matter? The other thing I think that is important is getting this information to our neurology colleagues, because, we're all talking about treating hearing loss with cognition as a confounder. But what about all these patients sitting in the neurologist right now with hearing loss as a confounder?
I've given multiple talks to grand rounds and journal clubs to the neurologists because they do see it, and they don't realize how many of their patients have untreated hearing loss or undertreated hearing loss. I agree 100%. And so that's another area, and that's where the bridges will happen, right? And so I think, but they are, they usually want people who've already had, extensive neuropsychological testing before they kind of get into their realm. And so there's going to have to be some intermediary place for people to land. And I'm not sure where. It might be a specialty. maybe it'll be gerontology, the geriatric field in internal medicine, or, some allied, somebody takes it, and obviously then it also comes down to some of the difficulties of remuneration in the elder patients based on the Medicare system, whether or not you can remunerate people enough for their time to do this extensive work that's pretty time consuming. So there's a lot of things that are going to be fascinating to work out, and I'm glad you're working on it and talking about it.
Great. Well, thank you.
Well, Jed, tell me, what's your favorite sound? I love asking people this because I always want to know what people's favorite sound is.
I'll tell you, I think that probably one of the most soothing sounds to me is if I wake up in the morning on a Saturday and it's pouring rain and I don't have to get out of bed. That's probably the best sound that I can think of.
That's nice. Yeah, so it's an interesting sound, right? Because it could be considered a dreadful sound Monday through Friday when you have to get up and you don't want to, you maybe want to sleep a little bit longer. That's great. So, and the other thing I always like to ask, if you're, getting a lifetime achievement award, who would you thank for helping you get to where you are today?
I think probably one of the people that has had the most meaningful on a professional level to me. I don't know if you know Miles Pinzak at University of Cincinnati. He's just a hero in my book. And actually, the reason why I do cochlear implants is when I was in my last year of training, coming to, West Texas where there's nobody, he said, who's doing cochlear implants out there? And he's like, you should do cochlear implants. And he was just so encouraging. And that's really what kind of started.
Bringing access, right? Doing it more locally, bringing better access. It's great. Yeah, that's awesome. Well, this has been a great conversation, Jed. It's a great topic. I think there's going to be more to happen and more to do it. But for the audience, this is Dr. Jed Grisel. He practices at Head and Neck Surgical Associates. Jed, if people wanted to get a hold of you, how would they do that?
So probably the best way is just send me an email, jgrisel, JGRISEL @WF.net, jgrisel @WF.net.
Okay. And how about your practice, if they wanted to find you in your clinical practice?
If you just Google, it's actually Texoma ENT and Allergy. It's complicated in the way the names are, but if you just Google Texoma ENT and Allergy, that's how you can get a hold of us.
That's great. Well, this has been a great episode. I really appreciate you coming in, sharing your thoughts and perspective, and thanks for coming on. And I appreciate it. Thanks.
Thanks, Mark. Appreciate it.
Been great.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.